Welcome to this video series on clinical examination brought to you by the Department of Clinical Medicine at the Faculty of Medicine, Colombo. Now, our objective in producing this series is to give you an overview of the correct technique of the clinical examination, at the same time pointing out some of the common mistakes made by the students. In this step, we deal with the respiratory system. I thank Ajit, who is here today, for volunteering for this program. Traditionally, we perform the clinical examination first by doing a relevant clinical examination of the general body, then proceeding into examine the neck and the thorax. You should begin the examination as you approach the patient. Stand back and use your wide-angle lens. You might observe whether the patient is comfortable, whether he can lie comfortably on bed without becoming dyspneic. Has he lost weight recently? Any signs of cachexia might indicate possible tuberculosis or carcinoma. As you approach this patient, look at his face. Look at the conjunctiva. Is there any evidence of polycythemia or anemia? Look at the lips and the tongue. Do you put that down? Is there any evidence of cyanosis? The beefy red tongue of polycythemia with central cyanosis is characteristic. Look for any evidence of facial edema, any swelling in the face and the neck that might indicate presence of either cor pulmonale or SVC obstruction. Patient's hands give us very valuable information. Look at the nails. Now, are there any nicotine stains? That might indicate the patient is a smoker. Look for clubbing. Clubbing is one of the very important physical signs in the respiratory system. Pick your patient's hands to eye level and look at the angle between the nail bed and the nail. One of the earliest manifestations of clubbing is the obliteration of this angle. Later on, this can progress into increased curvature of the nail, later on going into gross clubbing, which involves the whole pulp. Sometimes it's associated with changes in the wrist joint, hypertrophic pulmonary osteoarthropathy. If the patient is hypoxic and cyanosed, you might look for any evidence of carbon dioxide retention. He will have a bounding pulse, warm hands, and a flapping tremors. Then proceed to look at patient's feet. Of course, you might notice clubbing in the toes, but important thing is to look for any evidence of fluid retention, pitting edema in the patient's feet. Presence of pitting edema or fluid retention in a patient with a respiratory problem might indicate either cor pulmonale. Once you finish the general examination, you proceed to the examination of the neck and the chest. This we do in 4 steps: inspection, palpation, percussion, and auscultation. Let's start the inspection by first looking at the patient's neck. There are many things again you might observe with the neck. You look for any scars, Barb's scars, any lumps, perhaps lymph node masses. Look for the use of the accessory muscles, which might indicate that the patient is in some respiratory embarrassment. Usually, between the suprasternal notch and the cricoid, you can insert about 3 fingers. But When there is hyperinflation of the chest, like in a chronic asthmatic or chronic obstructive airway disease, this distance is greatly reduced. Look at the chest. Look at the skin. Are there any distended veins? Distended veins in the neck, in the chest, coupled with engorged veins in the neck, particularly if they are non-pulsating, might indicate the presence of SVC obstruction. Distended neck veins with prominent A wave suggest the presence of cor pulmonale. Look for any radiotherapy marks on the chest. Sometimes there may be small telangiectasia as a result of radiotherapy. Look for thoracotomy scars and look for any suprasternal and supraclavicular, intercostal and subcostal recession. This again indicates that the presence of very high pressure waves or pressure gradients inside the pleural cavity, particularly in case of chronic obstructive airway disease. Chest shape is also important. There may be certain skeletal deformities, pectus carinatum, pectus excavatum, and in case of long-standing obstructive airway disease, barrel-shaped chest or increase in the anteroposterior diameter. Sometimes students often forget to examine the back. Look at the back. Run your finger down the spine and look for kyphoscoliosis. Take a side view and estimate what the anterior posterior diameter is. To judge whether there's barrel-shaped chest, this is the best view. Next we look at the respiration or the breathing movements, and for this we use a tape measure. You measure at the level of the nipples and ask the patient to take deep breaths in and out. You also should look at the type of the breathing, whether there is thoraco-abdominal, and also take this opportunity to count the respiratory rate. When you count the respiratory rate, make sure that the patient is not aware that you are counting the respiration. Next, you compare the size, the symmetry of the movements, which is a very important step at this point, because if the movements are reduced on one side, then that indicates that there is some problem on that side. For this purpose, you take a step back. Take a tangential view at the chest and ask the patient to take one or two good deep breaths. Next, we proceed to the second step of the examination, namely palpation. We begin by palpating the neck. When you palpate the neck, you should do that from the front as well as from the back. You look for the lymph nodes. You get the patient to relax the neck, flex the neck a little, and then feel all the lymph node areas, submandibular, submental, along the carotid sheath, as well as supraclavicular and the scalene node. The best position to palpate the neck is from behind. Pay particular attention to the supraclavicular nodes as well as the scalene node. The enlargement of these lymph nodes might indicate the presence of carcinoma or tuberculosis. Another important structure in the neck that you should feel at this stage is the position of the trachea. There are many ways of doing that. One way is to follow the trachea with your index finger and then assess whether the trachea deviates to the right side or to the left side. But remember that this is little uncomfortable. So always tell the patient, explain to the patient that this procedure may be little uncomfortable as you will be feeling deep. The second method of palpation for the trachea is to assess the distance or the gap between the heads of the sternomastoid and the trachea. For this, what you do is you keep one finger on the sternoclavicular head, the other one, the ring finger on the other sternoclavicular head, and assess the space between the trachea and the sternoclavicular mastoid, the head here. Usually trachea is slightly deviated to the right side. But in case of a gross deviation, you should suspect fibrosis or lung collapse, where it is deviated to the same side or pulled to the same side. In case of a large pneumothorax or a large pleural effusion, it is pushed to the opposite side. Once you ascertain the position of the upper mediastinum, you should proceed to the apex of the heart. You look at the apex of the heart and estimate in relation to the mid-clavicular line whether the apex is shifted or not. Provided the heart size is normal, shift of the cardiac apex indicate the shift of the lower mediastinum. Another important aspect in the palpation of the chest is the reassessing the symmetry of the thoracic movements. For this purpose, you divide the chest into upper, middle and lower and assess the movement in each of these zones separately. You keep your hands like this, bring your thumbs together and ask the patient to take a deep breath. Your hand should be relaxed, should be free to move, should be grasping the chest well. Assess the movement of the upper chest, particularly the apices, by keeping your hands on the upper part of the chest. Look at the movements of your thumb. Are they moving symmetrically? You should repeat the same process in the back. But for the sake of the patient's comfort, we usually finish inspection, palpation, percussion and auscultation from the front and then proceed to the back. But for the demonstration purpose, I will show you the testing of the movements from the back. Even in the back, when you do this, keep your hands on the apices and the thumbs close to each other in the midline and ask the patient to take deep breaths in and out. Okay. Having tested the symmetry of palpation, then you move on to testing the vocal fremiters. The vocal fremiters is, we use the phenomena of the sounds that are conducted through the lung tissue pleura to the chest wall when the patient makes a sound, preferably a low frequency sound like 99 or anuname. So you use your ulnar side of the hand and you keep the ulnar side on the rib spaces and not on the ribs. It's not important to check in every rib space. You can test that in different zones, and as you move your hand low down in the chest, remember to move your hand away from the midline. Because as you know, ribs, when they come close to the sternum, the lower ribs are crowded to each other. Therefore, there's hardly any space between the ribs. So when you go down, you keep your hand in the rib spaces and move it away from the midline. 99 කියලා කියන්නේ
99
ආයිසරය
99
ආයිසරය
99
ආයිසරය
99.
Test the corresponding sides. And also, don't forget that there is a lateral side to the chest as well. So remember to ask the patient to keep their hands above the head and to test the axillae and the lateral part of the thorax as well. Okay. Now I think at this point I should ask you to stop the tape and think of the conditions where the vocal premitus is increased and the vocal premitus is decreased. Can you make a list? And can you explain why in each of these conditions the vocal premitus is increased or decreased? The third step in the examination of the neck and the thorax is the percussion. But before we proceed to percussion, let's take a minute to think about the answers to the questions I posed in the previous section. We talked about the vocal premitus. The vocal premitus is increased in case of consolidation, fibrosis, and is reduced in cases where the visceral pleura is separated or is separated away from the chest wall, such as pneumothorax and the pleural effusion. Let's look at the percussion. When you percuss, the technique is very important. Remember, all the movements from the percussion should occur at the wrist joint. The striking finger, this finger in this case, should hit the other finger at right angles. And only one finger should be touching the chest. These two fingers should be away from the chest wall, otherwise it damps the noise. The striking finger should be lifted off soon after it strikes. In the percussion, also like in the vocal premitus, you should test in each the rib spaces the corresponding levels, and as you go down, you move the finger away from the chest wall. And you start percussion by percussing the apices. Here you can percuss the clavicles and then go down the chest wall with your fingers. Don't forget to percuss the axillae and the lateral part of the chest and also the back. Now, can you say what conditions the percussion note is increased? Well, remember that there are certain areas where the percussion note is dull. For example, in the cardiac dullness and the liver dullness. And obliteration of these areas, obliteration of the normal dull percussion is also important, and it's seen in cases where there's hyperinflation of the chest as well as in pneumothorax. So every time you percuss, you ask the question yourself, is the percussion normally resonant or is it hyperresonant in case of pneumothorax or in hyperinflated chest or in emphysematous bully, or the percussion note is dull like in fibrosis, cavity or the consolidation. Percussion note is stony dull in case of a pleural effusion. I suggest you stop the tape now and try to think how you can differentiate consolidation from the cavity or from fibrosis clinically. Can you differentiate consolidation from a pleural effusion? You stop the tape and discuss among yourselves. The auscultation is the most difficult part to demonstrate in this presentation. When we auscultate for lung sounds, we use the bell of the stethoscope. It's advisable to use the bell because the rubbing of the diaphragm on chest wall hair can produce sounds very similar to crepitations. When you auscultate, there are 4 aspects you should pay attention to. Intensity or the loudness of the breath sounds, which reflects the air entry. The character of the sounds, whether it's vesicular or bronchial. Whether there are any added sounds such as crepitations or rhonchi. And lastly, the vocal resonance. Intensity of the breath sounds are reduced diffusely in conditions such as severe bronchospasm, but localized reduction of the breath sounds are heard in case of pneumothorax or pleural effusion. In case of the latter, the large pleural effusion, breath sounds may be totally absent. When you listen for the character of the breath sounds, you should learn to forget the lung sounds, forget the heart sounds, and then listen, paying attention to the lung sounds alone. Vesicular sounds, vesicular breath sounds are softer with a longer inspiration without a gap between the inspiration and the expiration. In contrast, bronchial breathing, bronchial breath sounds are much harsher and they sound somewhat like this. Usually there is a gap between the inspiration and the expiration as well. There are different types of bronchial breathing. One of bronchial breath sounds called amphoric breathing is thought to be heard over the cavities. Bronchial breath sounds, bronchial breathing is characteristically heard over consolidations, fibrosis, and over cavity. Even in lung collapse, if the main bronchus is patent, you can hear bronchial breathing. Coming to the added sounds, there are 2 main types of added sounds, crepitations and rhonchi. In case of crepitation, there are fine crepitations and coarse crepitations. The fine crepitations are heard in case of pulmonary edema, fibrosing alveolitis, and in very early stages of pneumonia. Coarse crepitations are characteristically heard in bronchiectasis, lung abscess, and in pneumonia during the resolving phase. Pleural rub can be mistaken for crepitations unless you are careful. Pleural rubs are they sound much closer to the stethoscope, and it can be changed in case of when the stethoscope is pressed over the chest wall, they might become louder. Rhonchi, as you know, indicate the narrowing of the bronchi and the bronchospasm. Testing for vocal resonance helps you to reinforce the information you obtained when you tested the vocal fremitus. Vocal resonance is increased in the conditions where the vocal fremitus is increased and is reduced whenever the vocal fremitus is reduced, but generally speaking is much more sensitive test than testing for vocal resonance. 99 කියලා කියන බලන්න.
99.
දැන් මම ස්ටෙප් එක තියෙනකොට ඔය 99 කියලා කියන්නේ. When you test for vocal resonance, you should get the patient to say something in very deep a voice like 99 or 99. 99.
99.
I can.
99.
I can.
99.
I can.
99.
I can.
99.
Vocal resonance is increased characteristically over consolidation or cavity or fibrosis. Whispering pectoralogy is also something related to the vocal resonance, but here the difference is you get the patient to produce a very high frequency sound. රහසින් 1 2 කියලා කියන්නේ 1 2.
එකයි දෙකයි
Aye.
එකයි දෙකයි එකයි දෙකයි.
Now, usually when you listen with the stethoscope, you cannot hear the words clearly. But in case of, if the whispering pectoralogue is present, you will be able to hear these words very clearly when the stethoscope is placed over the chest wall. Whispering pectoralogue is increased or is present whenever there is bronchial breathing. So it's a useful physical sign to confirm the presence of bronchial breathing. What I hope to achieve in this tape is to help you in developing the skills of examining the respiratory system. There's one way, only one way of mastering this skill. That is by repeating this drill over and over again on normal individuals as well as on your patients. Be grateful to your patients for allowing you to learn from them. Be gentle. Perfect your skill. You owe it to your patients. Thank you.